14, question number 14. Flexner-Wintersteiner rosettes are seen in neuroblastoma, medulloblastoma, retinoblastoma, ependymoma. Answer to this question is a retinoblastoma. So let us look at what are rosettes and where do we see those rosettes. Rosettes are typically tumor cells around tumor cells in a circular fashion, and in the center sometimes there might be the cytoplasmic process of the tumor cells. So there are different types of rosettes. Which are those different types of rosette? Yeah, few basic things we need to understand here. First one is a Omer-Wright rosette. Omer-Wright rosette is seen in neuroblastoma, medulloblastoma, peanuts and pineoblastoma. Omer-Wright rosette. So peanut includes your Ewing sarcoma as well basically. So neuroblastoma, medulloblastoma, peanut and a pineoblastoma. Omer-Wright. Flexner-Wintersteiner rosettes, retinoblastomas, pineoblastomas and medulloepithelioma. You need not remember that. Retinoblastoma, pineoblastoma. So pineoblastoma can have both Omer-Wright rosette and also Flexner-Wintersteiner. Next is true ependymal rosettes. So very important is true ependymal rosettes seen in ependymomas. They are called ependymal rosette. In ependymomas, there is one more rosette, pseudorosettes. They are called perivascular pseudorosettes seen in ependymoma, medulloblastoma as well. Then peanut and neurocytomas, glioblastoma, so many of them. But anyways, remember, so very important is peanut you can see Omer-Wright rosettes and also you can see perivascular pseudorosettes, and ependymoma you can see true rosettes as well as pseudorosette. Retinoblastoma, Flexner-Wintersteiner, pineoblastoma, Omer-Wright and Flexner-Wintersteiner rosettes. Question number 15. So let us look at this question. 5-year-old kid comes to OPD department with recurrent history of bilateral LRI, now presented with pneumonia and impending sepsis. So he's having recurrent infection, LRI, and also he's having pneumonia, now sepsis. Sputum culture shows streptococcus as well as Haemophilus. So it is a recurrent infection in a 5-year child, pneumonia, sepsis also, impending sepsis. The patient did not have any external anomaly. Which of the following is the most appropriate diagnosis? DiGeorge syndrome is not the answer. Why? Because does not have external anomalies. DiGeorge will have a cleft palate. That will be the external anomaly that you might be seeing. That is not the case here, right? So it is not. It is not even acute leukemia. Why? Because acute leukemia patient can have infection, not a problem, but will have other manifestation, anemia, bleeding. Blood examination should have shown some blast. That is why this is not the case. Then selective IgA deficiency is also not the answer. In selective IgA deficiency, yes, there can be upper respiratory infections happening, but usually not leading to sepsis. That's one thing. And second, it will not be severe. IgA deficiency will be mild, so it will present with chronic diarrhea and mild upper respiratory tract infection, but usually that presents more in adulthood rather than in childhood. So answer is X-linked A-gamma globulinemia, also called as Bruton's disease. Bruton's gamma globulinemia, where there are all immunoglobulin reduced. So basically a bacterial infection suggests there is a deficiency of humoral immunity here. In the explanation, I have given you all the different diseases and their defects. The other things you can refer from the class notes. You will be having these things basically. So which disease will have what problem, you will be knowing that. And yes, that is what is. Next question. 65-year-old man has felt vague abdominal discomfort for past 2 years. So it's a 65-year vague abdominal discomfort for past 2 years, which was ignored. So he's having from 2 years, he ignored it. On physical examination, no abnormal swelling seen anywhere in the body, nor there was any organomegaly. So there was no organomegaly, no abnormal. That is what is there. Abdominal CT shows a 25 centimeter retroperitoneal mass with a necrotic area. So very, very important. There is a retroperitoneal mass, a huge retroperitoneal mass. Retroperitoneal tumors usually can be sarcomas or otherwise lymphomas also can be there. But however, no abdominal lymph nodes that has been written. That means it cannot be a lymphoma here. So option B is straight away ruled out here. Stool specimen tested for occult blood is negative. So there is no blood in the stool. So it is unlikely to be option A. It is not adenocarcinoma of colon as well. Now, is it a melanoma? Is it a liposarcoma? Given with the history retroperitoneal mass, I would like to make a diagnosis of liposarcoma. If it was melanoma, melanoma usually can occur in foot or in skin anywhere, foot commonly, and there can be lymphadenopathy that will be seen there. Question number 17. So the next question we are talking here, let us look at this. Which of the following correctly depicts cross-matching done before the blood transfusion? So what is cross-matching? So four options are given. Donor's serum, patient's RBC, Coombs serum. This is not the case. Why? Because in a cross-matching, your main aim is to detect antibodies against the donor RBC. So you have to be taking serum from the patient. So let us look where are patient serum. 1 and 2 options are there. So C, A and D are ruled out already. Now, so you should take patient serum, we know that. Then we should be taking donor's RBCs or donor serum. Answer is donor RBC, not donor serum. So basically you are mixing the patient serum with the donor's RBC so that if there are any antibodies in the patient serum against the donor RBC, they will end up killing those RBC and you will be knowing it before the reaction happens. So basically this is done to prevent the hemolytic transfusion reactions. Right? Next question. A newborn presents with severe umbilical cord bleeding. So basically there's an umbilical cord bleeding and you need to know what are the DDs for umbilical cord bleeding. Very commonly umbilical cord bleeding can be because of vitamin K deficiency. It can be because of factor 13 deficiency. It can be because even of a Glanzmann thrombasthenia as well. GT, Glanzmann thrombasthenia. So let us look further. Investigation shows PT 25, APTT 60 seconds. Both of them are increased. Normal value of PT 10 to 15 seconds, normal value of APTT up to 45 seconds. So it is both of them are increased. TT and D dimers were normal. That means fibrinogen probably is normal, DIC is ruled out. Hemoglobin is 13, platelet is 2 lakh, doesn't matter. Now what is the likely diagnosis? It cannot be factor 13 deficiency because all will be normal in factor 13 deficiency. It cannot be Glanzmann thrombasthenia. Why? Because PT, APTT will not get affected in Glanzmann thrombasthenia. It is not even DIC. Why? Because TT is normal, D dimers are also normal. Answer is vitamin K deficiency. In fact, this is the most common cause of umbilical cord bleeding in the newborn in our country. Next, let us look. This is a lengthy question, and for lengthy questions always I say look at the options and the image first. So they have given a lengthy question. Which of the following is the most likely diagnosis? Given options are intestinal TB, Crohn's disease, ulcerative colitis, ischemic necrosis. So looking at the image itself, I can see something from here itself. This is your giant cell that you are seeing. The moment I am seeing giant cell, and of course given the options, it is from somewhere in the intestine. So I would definitely rule out these two, either intestinal TB or a Crohn's disease. Now look at on the other side. This is your, I hope all of you are able to see, these are glands here, and that means this is the mucosa. So, and all this is your inflammatory cells, and inflammatory cells is throughout here. So it is a transmural, we can say. So it can be transmural. That is what I am seeing here. Anyway, let me read at the question now. So I have idea of only what 2 DDs here or related ones. I can straight away look at that. 30-year-old man is admitted in hospital for evaluation. Doesn't matter. 6 weeks history of colicky, abdominal pain, diarrhea with occasional blood. So that can happen with any of your inflammatory body disease. It can even happen with TB as well. 3 days after admission, he suddenly develops peritonitis and sepsis, which is unlikely in tuberculosis. Sepsis, etc. is unlikely, and it's going to be long duration in TB. Despite appropriate care, he dies. So basically, he died of sepsis. Autopsy examination shows fibrinous exudates over peritoneal and serous surface. So very important, whenever you see such fibrinous exudates, again it is unlikely of tuberculosis. Usually in TB, what would have happened? In TB, what would have happened is there would be a fibrosis that would have set in if it was actually a TB. Anyway, so let us look, and punctate opening is seen in the wall. So what is this telling now? Punctate opening is nothing but this is telling perforation is seen in the wall, and this is the one which would have led to peritonitis also, by the way, right? In the wall is seen in the wall of thickened loop. So there are thickened loop of small intestine. So this can indicate query strictures. So I do not know whether they are strictures. Okay, now look further. It gives several lengths of small and large intestine also thickened and adherent to each other. So there is adhesion happening. Now everything is fitting into Crohn's disease here. So answer to this question is Crohn's. So basically looking at this, when you look at lengthy questions, the clinical vignettes, they are sometimes more easier than the normal one. So let us look further. Next, also slightly bigger question. Let us look at further. What does it say? Which of the following best describes pathogenesis in the patient? So we need to know what is the pathogenesis in this. So what is the question says? 43-year-old woman comes to physician with 2-day history of mild nausea, increased urine urgency, frequency and constipation. So she is having nausea, urgency, etc. She has had a 4.5 kg weight loss during past 2 weeks and 3-week history of vaginal bleed. So important history has been given. There is history of weight loss and bleeding per vagina. Pelvic examination shows nodular cervix which is irregular, friable posterior lip and rock hard irregular immobile pelvic mass. So in a cervix there is a pelvic mass given with the age history 43-year and weight loss, etc. I can suspect query CA cervix. Basically I am going to suspect fitting into CA cervix. Now let us see further. Examination biopsy from the specimen of the cervix of the anterior wall shows well differentiated keratinizing squamous cell carcinoma. So basically it's a squamous cell carcinoma of cervix, which is most common, by the way. So what is the question asked? Which of the following best describes the pathogenesis? Option 1, inactivation of P53, insertion of viral promoters adjacent to cellular growth factor genes. Basically that is nothing but adjacent to the proto-oncogenes, translocation of MYC, inhibition of apoptosis by BCL2. So answer is option A is the correct answer here, inactivation. Why? Because viral proteins E6 and E7 inactivate P53 and also phosphorylate RB. Thereby, if they phosphorylate RB, they dysregulate the G1S checkpoint and they inactivate P53. Both G1S and G2M are also affected. So both the cell cycle checkpoints are freed, and that is why there will be rapid proliferation of the cell happening. Option D, inhibition of apoptosis by BCL2 is for follicular lymphoma, translocation of MYC gene for Burkitt lymphomas, CA colon, and even neuroblastomas. By the way, they are CMYC and MYC here, and even lung carcinoma, LMYC, right? Yeah. Now, next question, let us look what is this now. Again, a lengthy one. Let me look at the options first. Which of the following is the most likely cause of this patient's symptoms? So question says, what is the most likely cause of this patient's symptom? Carcinoid syndrome, hypercoagulability due to advanced malignancy, Budd-Chiari syndrome, reduced production of anticoagulants by the liver due to metastasis. So basically there are multiple options. Let us look at further now. What is the question say? 63-year-old man is brought to emergency because of 4-day history of increasing severe left leg pain, swelling of the left calf. Basically this is query DVT now itself, basically looking at the option, because there are options of thrombosis, Budd-Chiari, which are both thrombosis, thrombotic manifestation. So this is query DVT. He has 1 month history of increasing severe upper mid thoracic back pain. So he's having some back pain for last 1 month here. So he is having back pain for the last 1 month. During this time he has had a 9 kg weight loss. So very important, there is a weight loss, back pain, and also query DVT now. He has no history of major medical illness. His only medication is ibuprofen, nothing else is there. 180 centimeter tall, a weight is 82, BMI is normal, his vital within normal limits, all are normal. I do not want to this now. So basically he's having back pain. Anything is given, let us look at that. On examination, lower extremities are palpable, pulses are palpable bilaterally. Remainder of physical examination, no abnormalities. An X-ray of thoracic, no abnormalities in the thoracic spine. A CT scan shows, CT abdomen shows 3 centimeter mass in the body of pancreas. So now very important is there is a tumor in the pancreas. There are liver mets and also superior mesenteric artery has been involved here. Possibly the back pain might be explained because of a thrombosis that might be happening in the pleural, or that is in your pulmonary, or maybe even the Mets also. We do not know because bone skeletal survey has not been given here. Doesn't matter. Ultrasonography lower extremity shows a femoropopliteal venous clot. This is what is your DVT. That is what is a manifestation. So symptoms of these patients are due to DVT basically. That is what is a symptom. So is it because of carcinoid syndrome? Answer is no. Carcinoid syndrome will have diarrhea, etc. That is not the case. And look at hypercoagulability due to advanced malignancy. Budd-Chiari. This is not a Budd-Chiari syndrome. Budd-Chiari syndrome will be having a venous thrombosis in the hepatic vein, hepatic venous thrombosis, which will lead to hepatomegaly as well as ascites. That's not the case here. Reduced production of anticoagulants. So now tell me, why is the thrombosis happening? Very important. Pancreatic carcinomas can show Trosso phenomena. Increased thrombosis can happen, right? Yes, and that is because of paraneoplastic. So option B is the correct answer, not the option D here. It has nothing to do with liver metastasis. Whether liver mets has happened, not happened, doesn't matter. It will be the same here. Next. A 35-year-old housewife comes to physician because of pain and swelling of dorsum of her right thumb, which is sustained from burns of hot oil when she was frying. So basically she had burns due to frying oil. From the hot oil she's got burns. Her temperature is normal, 38, slightly more, by the way, not normal, 38 is more. Examination, that can happen because there will be inflammation happening whenever there's an injury, that can lead to fever. Examination of the right thumb shows edema around a flocculent erythematous lesion at the trauma site. So there is a erythematous flocculent lesion at the trauma site. The area is extremely tender to palpation. So obviously this flocculent erythematous area is because of venous congestion happening, because of inflammation, and it is flocculent because of there is an exudation of plasma protein. Whenever there is an injury, there has to be inflammation happening, and for inflammation there should be exudation of plasma protein. What is the question asked? Most likely primary mechanism for development of edema in this patient. So why is edema happening? And this edema, remember, is an exudative edema. It's an exudative edema because of inflammation here. So what is the answer to this? Damaged basement membrane. That is not the case, because basement membrane damage is the one which is leading to diapedesis, not to this. Increased hydrostatic pressure. No, increased hydrostatic pressure can give rise to transudative edema, not exudative edema. Release of thromboxane. That is also not the answer, because that will lead to platelet aggregation. Option is separation of endothelial cell. This is called as endothelial contraction or retraction. Same words, contraction or retraction. Endothelial contraction, the endothelial cells will contract, and especially in burns we call it as a delayed type of endothelial contraction or retraction. Next question. Which of the following is the most important in pathology of SARS-CoV-2 infection? Basically SARS-CoV is your causative organism for COVID-19. Infection causing the current pandemic, that also has been given, by the way. So in the current pandemic, SARS-CoV, what is the most important pulmonary pathology? That is what is asked, because in SARS-CoV there are multiple pathologies that are happening. Primary, most important is the pulmonary pathology, by the way. Let us look at what are the options. Death of type 1 pneumocyte, type 2 pneumocyte, death of ciliated epithelial cells, death of alveolar macrophages. Yes, so don't confuse here. Ciliated epithelial cells, especially in the upper respiratory tract, it can infect, but that is not the most important for pathogenesis. Most important for pathogenesis, basically SARS is causing your ARDS. So ARDS is happening primarily because of death of type 2 pneumocyte. So SARS-CoV-2 infects type 2 pneumocytes, kill the type 2 pneumocytes. Type 2 pneumocytes have two functions. One is to secrete surfactant, and second is regeneration. Surfactant secretion is gone, that is why lung cannot expand, it will collapse. More important, it will also start damaging type 1 pneumocytes. When type 1 pneumocytes die, there are no type 2 pneumocytes for regeneration now. That is why problem is happening. And that is why the problem happens with those people who are already compromised. Someone who is already compromised, little bit of damage of type 2 pneumocyte, no regenerative capacity, that's why death will happen. Okay. Next. Bone marrow examination of a patient is given as follows. Which of the following is not a blood finding in this patient? So question specifies which is not a blood finding. So this is a bone marrow aspirate of a patient with renal failure that has also been given. So there's a renal failure and you have done a bone marrow aspirate and this is a bone marrow aspirate. I can definitely see all these are plasma cells, eccentric nucleus, and you can see that these are all plasma cell. Even Mott cells are seen. Mott cells are nothing but multiple vacuoles inside the plasma cell. This is your Mott cell, by the way. So what's your diagnosis? Looking at this, multiple myeloma, which can present with renal failure, right? So what is the question asked? Which of the following is not a blood finding in this patient? Increase in alkaline phosphatase, increase in ESR, increase in calcium, reversal of AG ratio. We all know increase in calcium will happen because of lysis is there, lytic lesions are there. Reversal of AG ratio, that is also true. Why? Because albumin globulin ratio, the globulins will start increasing because of M protein. Remember, M proteins are your globulins. That is why there will be reversal of AG ratio. Very important in multiple myeloma, because there are more globulins, this also will end up increasing the ESR. Globulins will increase the ESR. Reduction in albumin also can help in increasing of ESR, but anyway, most important here is globulins, which will increase the ESR. Alkaline phosphatase will be normal. So this is the correct answer here. So answer to this is option A. This will be normal because there is no osteoblastic activity happening in multiple myeloma. It's only osteoclastic activity that is happening here. Next. Question number last one. 55-year male presents with easy fatigue recurrent infection. Physical examination shows spleen 4 cm below the costal margin. So easy fatigue, spleen enlarged is there. Blood examination, hemoglobin 9, TLC 3000, platelet 45,000. So there is thrombocytopenia, there is anemia, and there is leukocytopenia. Pancytopenia a patient is having. So pancytopenia with splenomegaly. Peripheral blood smear is as shown. Which of the following is appropriate treatment in this patient? So question asks this treatment here. So blood smear is shown as this. What are we seeing here? All these are, if you look at this, hairy cells. So these are hairy cells. So what is your diagnosis? Hairy cell leukemia. So this is a hairy cell. What is the treatment for hairy cell leukemia here? So steroids, all trans retinoic acid. This cannot be the answer. All trans retinoic acid is used in AML-M3 or also called APML, acute promyelocytic leukemia. That is not the case here. Next is your bortezomib. What is this bortezomib? Bortezomib is used in multiple myelomas. That is not the case here. Steroids in generally we can use anywhere, but specific answer here is cladribine. Cladribine and pentostatin, two drugs that are used in hairy cell leukemias are cladribine and pentostatin. Yes, so these were about pathology questions, and looking at this, I hope all of you have done it well.